Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 321 of our pharmacotherapy series, which majors in shock. The first question reads, DEB, a 71-year-old woman, presents to the emergency department from a skilled nursing facility with a several-day history of low-grade fever, rigors, and chills. She does not report a history of nausea or vomiting but had exceedingly poor oral intake for several days prior to admission. DEB has a history of diabetes mellitus type 2, hypertension, chronic kidney disease stage 2, dyslipidemia, coronary artery disease, obesity, and peripheral arterial disease. She has a history of a transient ischemic attack and right lower extremity below the knee amputation. Physical findings include a temperature of 38.7 degrees Celsius, BP 95 systolic 60 diastolic, pulse 120 beats per minute, and respiratory rate of 28 breaths per minute with oxygen saturation 95% on 2 liters per minute nasal cannula. DEB weighs 102 kilograms and is 65 inches tall. A Foley catheter is placed in her bladder and her urine output is 0.4 milliliters per kilogram per hour. The chest radiograph shows an enlarged heart, low lung volumes, and a distended, gas-filled stomach but no focal airspace disease, pneumothorax, or pleural effusion. Her left lower extremity has foul-smelling, purulent drainage from the posterior heel, surrounding erythema with macerated areas, and the heel is tender to the touch. DEB has 3+ edema in the foot and lower extremity but no other significant findings aside from the heel ulcer. The patient also has a large stage 3 sacral decubitus ulcer with several open wound areas and serosanguinous drainage.
Her pertinent laboratory values are as follows. Her WBC count is 19,500 cells per microliter. She has a BUN of 58 mg per deciliter and a serum creatinine of 2.2 mg per deciliter. Her serum sodium levels are 131 milliequivalents per liter. Her serum glucose levels are 58 mg per deciliter and her serum albumin is 1.6 grams per deciliter. Her ABG measurements on 2 liters per minute nasal cannula, i.e. FiO2 27%, are as follows. P. AO2 of 98 mm of mercury. PaCO2 of 32 mm of mercury. And a bicarbonate of 16 milliequivalents per liter. She has a pH of 7.31.
Urine, sputum, blood, and deep tissue wound samples are sent for culture and sensitivity. A fluid bolus of 1000 milliliters of normal saline solution is given. Arterial and pulmonary artery catheters are inserted, revealing the following hemodynamic profile. BP, systolic diastolic and MAP are 90-48 and 62 mm of mercury respectively. Heart rate is 122 beats per minute. Cardiac output is 7.1 liters per minute. Cardiac index is 3.4 liters per minute per meter squared. Pulmonary capillary wedge pressure, 10 mm of mercury. Systemic vascular resistance is 720 dyne SCM power -5 watt. Hemodynamic and clinical features of DEB are consistent with septic shock. DEB would not be classified in septic shock at this time because she has not been adequately fluid resuscitated. Though, she would be classified as having sepsis because of the manifestations of infection and organ dysfunction. Hemodynamic signs consistent with sepsis include hypotension, tachycardia, elevated cardiac output, low systemic vascular resistance, and low pulmonary capillary wedge pressure. Although the absolute value for cardiac output is high or at the upper limits of the normal range, in septic shock it is inadequate to maintain a BP that will perfuse the essential organs in the face of a decreased systemic vascular resistance, evidenced by a low oxygen delivery and oxygen. DEB has a metabolic acidosis, that is pH of 7.31, Pa, CO2 of 32 mm of mercury, and a bicarbonate of 16 milliequivalents per liter, indicating anaerobic metabolism and lactic acidosis most likely caused by decreased perfusion, and a cardiac output that is inadequate to meet the oxygen requirements of the tissues. Other features consistent with sepsis in DEB include declining urine output indicating decreased renal perfusion, hypoglycemia, a rising WBC count, and a spiking fever. The next question reads, what factors should be considered in determining antimicrobial therapy in septic shock? What are the potential sources of infection in DEB? Systemic infection caused by either aerobic or anaerobic bacteria is the leading cause of septic shock. Fungal, mycobacterial, rickettsial, protozoal, or viral infections can also be encountered. Among sepsis syndromes caused by aerobic bacteria, gram-negative organisms, e.g., Pseudomonas, Enterobacteriaceae, and Acinetobacter, in decreasing order of frequency, are implicated slightly more often than gram-positive bacteria, e.g., Staphylococcus aureus, Enterococcus, Staphylococcus epidermidis, and Streptococcus, from highest to lowest frequency. Even these trends vary, however, depending on the infection site. For example, when an organism can actually be cultured in the blood, slightly more gram-positive infections, 35% to 40%, than gram-negative infections, 30% to 35%, are found. In non-bloodstream infections, e.g., respiratory tract, genitourinary system, and the abdomen, in descending order of frequency, 40% to 45% can be attributed to gram-negative organisms, and 20% to 25% are caused by gram-positive organisms. Polymicrobial infections make up the next largest group, followed by fungi, anaerobes, and others. In up to 33% of sepsis syndrome cases, no organisms can be isolated. Careful consideration of the patient's history and clinical presentation often reveals the most likely cause. Eradicating the source of infection involves the early administration of antimicrobial therapy, and, if indicated, surgical drainage. The use of an appropriate antibiotic regimen within 1 hour of the diagnosis of sepsis or septic shock is associated with a significant increase in survival. Appropriate cultures should be obtained before starting antibiotic therapy, unless this would result in a significant, that is greater than 45 minutes, delay in therapy. The selection of antibiotics should take into account the presumed site of infection, whether the infection is community or healthcare associated, recent invasive procedures, manipulations, or surgery, any predisposing conditions, drug intolerances, and the likelihood of drug resistance. Ideally, the primary source of infection can be determined and therapy specifically tailored to the most likely organisms. If the source of infection is unclear, however, early institution of broad-spectrum antibiotics against all likely pathogens is generally recommended while awaiting culture results. Empiric broad-spectrum therapy usually requires combinations of antimicrobials because of the increasing frequency of polymicrobial infections and antimicrobial resistance. Even so, there are no data demonstrating better outcomes with combination therapy over adequate monotherapy, except in severely ill, septic patients with a high risk of death. Empiric regimens must be determined by patient factors and broad enough to cover all likely pathogens. Mortality for septic shock may be as much as 5-fold higher when an empiric regimen fails to cover the offending pathogen. Because a wide range of variables must be considered in the selection of empiric regimens, e.g., anatomic site of infection, pathogen prevalence, resistance patterns, a specific regimen cannot be recommended for all episodes of sepsis or septic shock. Generally, empiric regimens target gram-positive cocci, aerobic gram-negative bacilli, as well as anaerobes and include 1. An anti-pseudomonal penicillin, 3rd or 4th generation cephalosporin, or carbapenem plus 2. Vancomycin to cover methicillin-resistant Staphylococcus aureus. Combination gram-negative coverage, e.g., an aminoglycoside, or a fluoroquinolone, is recommended for critically ill patients at risk of infection with difficult-to-treat, multidrug-resistant pathogens, such as Pseudomonas and Acinetobacter species. Additional coverage should be considered based on the presence of other risk factors, e.g., Candida species, or atypical pathogens. Individuals with diabetes mellitus are presumed to be at an increased risk of infection because of multiple host factors, including hyperglycemia-induced immunosuppression, vascular insufficiency, peripheral neuropathies, and colonization with Staphylococcus aureus and Candida species. The most likely potential sources of sepsis in DEB are a combination of skin and soft tissue infections. DEB has a severe diabetic foot infection involving her left heel with inflammation, purulence, and systemic manifestations of infection. She also has a large stage 3 sacral decubitus ulcer. A urinary tract infection and vulvovaginal candidiasis should be considered as well because of her history of diabetes. Other sources of infection are less likely based on her presentation. All IV catheters from the skilled nursing facility should be changed if possible. Infected pressure ulcers and diabetic foot infections are usually polymicrobial wounds. These infections should be treated with parenteral broad-spectrum antibiotics to cover methicillin-sensitive and methicillin-resistant Staphylococcus aureus, Streptococcus species, Enterobacteriaceae, Pseudomonas aeruginosa, and obligate anaerobes, e.g., Peptostreptococcus, Peptococcus, Bacteroides fragilis, and Clostridium perfringens. As such, empiric therapy should include vancomycin in combination with one of the following: piperacillin tazobactam, ceftazidime, ceftaroline, cefepime, aztreonam, or a carbapenem. If aztreonam or a cephalosporin is chosen, then metronidazole or clindamycin should be considered to cover anaerobic organisms, particularly for ischemic or necrotic wounds. Drainage, debridement, and wound dressing should accompany antibiotic therapy. Antimicrobial therapy should be adjusted once cultures are finalized. The next question reads, what are the immediate goals of therapy in DEB? How can they be achieved and assessed? The goals in treating septic shock, in addition to eradicating the precipitating infection, are to optimize oxygen delivery to the tissues and to control abnormal use of oxygen and anaerobic metabolism by reducing the tissue oxygen demand. Tissue injury is widespread during sepsis, most likely because of vascular endothelial injury with fluid extravasation and microthromboses, which decrease oxygen and substrate utilization by the affected tissues. The mainstay of therapy is volume expansion to increase intravascular volume, enhance cardiac output, and ultimately delay associated development of refractory tissue hypoxia. Increasing cardiac output with fluids will improve capillary circulation and tissue oxygenation by maintaining sufficient intravascular volume. At least 30 ml per kilogram of IV crystalloid fluid should be given within the first 3 hours of resuscitation. If fluids do not correct the hypoxia or if filling pressures are increased, the sequential addition of vasopressors and inotropic agents is indicated. Blood transfusions should be used if the hemoglobin is less than 7 grams per deciliter unless there is an active source of bleeding, severe hypoxemia, or a history of cardiac disease, in which case the hemoglobin value would be maintained at a higher value. Crystalloids with electrolytes to correct imbalances should be initiated to maintain the cardiac index goal as well as a MAP of 65 mm of mercury. Although MAP is not an absolute measure of blood flow to all vital organs, it is considered the therapeutic endpoint that will sustain myocardial and cerebral perfusion. A higher MAP could be considered in septic patients with a history of hypertension or those who clinically improve with a higher BP. After optimization with fluid therapy, vasopressor and inotropic agents are indicated if the patient remains hypotensive with a low cardiac index or if signs of inadequate tissue perfusion persist. The therapeutic goals used for hemodynamic resuscitation are controversial. The issue is whether therapy should be directed to physiologic endpoints of tissue perfusion or clinical endpoints, such as BP and urine output. The physiologic endpoints include clearance of blood lactate concentrations, base deficit (SvO2), and increased cardiac output. Serum lactate concentrations may be elevated through various mechanisms, e.g., tissue hypoxia, excessive beta-adrenergic stimulation, or liver failure, but are associated with worse outcomes regardless of the source. Lactate-guided resuscitation of patients in septic shock is recommended because of its association with a significantly reduced mortality rate compared with usual care. Many institutions have developed sepsis bundles that incorporate these same variables and therapeutic endpoints as early as possible in the treatment of sepsis. Sepsis bundles often include many additional issues addressed in the Surviving Sepsis Campaign guidelines such as ventilatory support, initial choice of antibiotics, glucose control, and stress ulcer prophylaxis. One study by Rivers al. combined physiologic and clinical endpoints of resuscitation during the early stages of sepsis. CVP, MAP, hematocrit, and ScVO2 were optimized during at least 6 hours of continuous care in the emergency department. This was compared to conventional therapy that targeted only CVP, MAP, and urine output. In-hospital mortality was significantly lower in the early goal-directed therapy, abbreviated as the EGDT group, 30.5% versus 46.5%, with AP equal to 0.009. Early goal-directed therapy was adopted as the standard of care in the treatment of sepsis and septic shock. However, there are several limitations to the early goal-directed therapy approach. As noted above, CVP is an unpredictable marker of fluid resuscitation and fluid overload is common after early goal-directed therapy resuscitation. Furthermore, the HCT target of 30% is unnecessarily high because transfusions of packed red blood cells to achieve a hemoglobin above 7 grams per deciliter do not increase SC/VO2. Finally, dobutamine could also be harmful if used to increase SC/VO2 in patients with unevaluated ventricular function. Several large, multi-center studies have shown no improvement in patient outcomes using early goal-directed therapy for severe sepsis and septic shock. Protocol-based resuscitation did not improve in-hospital mortality among 1,341 patients in the PROCESS study. In the ARISE and PROMISE studies, early goal-directed therapy did not reduce all-cause mortality compared to usual care. The mortality rates among the usual care groups from these trials, 18.9%, 18.8%, and 29.2%, were similar to the early goal-directed therapy group in the Rivers and colleagues study. These findings could be because of an improvement in our standard of care over that time period, chiefly the early identification and treatment. Nonetheless, the most recent Surviving Sepsis campaign guidelines have departed from the early goal-directed therapy-guided resuscitation strategy from the Rivers study. DEB should receive fluid boluses to maintain perfusion with a MAP of at least 65 mm of mercury. Reassessment of DEB's hemodynamic status should include a thorough clinical examination as well as assessment of available physiologic variables, e.g., heart rate, BP, SaO2, respiratory rate, temperature, urine output, and measurements from her PIA catheter. A minimum of 30 ml per kilogram crystalloid fluid challenge is recommended within the first 3 hours of resuscitation. Albumin may be substituted if large volumes of crystalloids are required, but hydroxyethyl starches should be avoided because of an increased risk of acute renal dysfunction and potential increased mortality. Continued, excessive fluid challenges to increase preload in DEB must be approached cautiously because she has an enlarged heart on chest radiograph, coronary artery disease, and multiple risk factors for heart failure. In addition, patients in septic shock are susceptible to experiencing non-cardiogenic pulmonary edema or ARDS, which can cause severe deterioration in pulmonary function. Fluid boluses should be given with ongoing monitoring to determine the CVP and pulmonary capillary wedge pressure at which cardiac output is maximal. This approach will avoid excessive CVP and PCWP pulmonary capillary wedge pressure beyond which cardiac output is no longer increased, reducing potential pulmonary edema. In summary, the immediate goal of therapy is to maximize oxygen delivery to the tissues. Fluid resuscitation is the mainstay of therapy and improves oxygen delivery by increasing cardiac output. However, inotropic and vasopressor agents are often required for additional cardiovascular support. A favorable response to immediate resuscitative efforts will be reflected by a reversal or halt in the progression of the metabolic acidosis, improved sensorium, and increased urine output. In DEB, surgical evaluation and debridement and selection of appropriate antibiotics while maintaining hemodynamic support are the clinical goals of therapy. The next question reads, DEB is given 3 1000 ml fluid boluses, and norepinephrine is begun at a rate of 0.05 micrograms per kilogram per minute. During the next 2 hours, she receives 4 liters of fluid in boluses, and the norepinephrine is increased to 0.3 micrograms per kilogram per minute to maintain her BP. She does not have signs of pulmonary edema. DEB has the following hemodynamic profile. BP systolic diastolic and MAP are 95, 48 and 64 mm Hg. The previous values were 90, 48 and 62 mm of mercury. Heart rate is 124 beats per minute. The previous value was 122 beats per minute. Cardiac output is 8 liters per minute. The previous value was 7.1 liters per minute. Cardiac index is 3.8 liters per minute per meter squared. Previous value was 3.4 liters per minute per meter squared. CVP is 12 millimeters of mercury. The previous value was 7 millimeters of mercury. Pulmonary capillary wedge pressure, 16 millimeters of mercury. The previous value was 10 millimeters of mercury. Systemic vascular resistance is 550 dyne SCM power -5. The previous value was 720 dyne SCM power -5. Urine output is 0.25 milliliters per kilogram per hour. The previous value was 0.4 milliliters per kilogram per hour. PaO2 is 85 millimeters of mercury. The previous value was 98 millimeters of mercury. PaCO2 is 36 millimeters of mercury. The previous value was 32 millimeters of mercury. Bicarbonate is 17 milliequivalents per liter. The previous value is 16 milliequivalents per liter. pH is 7.3. The previous value was 7.31. Oxygen delivery is 534 milliliters per minute. The previous value was 508 milliliters per minute. O2 is 198 milliliters per minute. The previous value was 324 milliliters per minute. So my question to you reads, which of the following therapeutic considerations would be reasonable for DEB at this time? Additional fluid boluses, an increase in the norepinephrine infusion rate, or initiation of a different vasopressor? DEB continues to be hypotensive despite a pulmonary capillary wedge pressure of 16 mm of mercury and a norepinephrine infusion rate of 0.3 micrograms per kilogram per minute. The goals of therapy remain the same, i.e., maximize arterial oxygen content and oxygen delivery to reverse cellular anaerobic metabolism. DEB's PaO2 of 85 mm of mercury correlates with an oxygen hemoglobin saturation of approximately 96%, which should provide an adequate arterial oxygen content. However, oxygen delivery still may be inadequate despite the cardiac index being above 3.5 liters per minute per meter squared because oxygen delivery and O2 have not reached normal levels. DEB's hemoglobin and hematocrit should be checked to ensure adequate oxygen carrying capacity in the blood. In addition, decreased tissue oxygen utilization can contribute to the continued acidosis. Further attempts to enhance the cardiac index and, hence, oxygen delivery are appropriate. DEB has a dilated heart and a history of cardiovascular disease and chronic kidney disease that will influence the choice of therapeutic options. Although fluid administration is the mainstay of therapy in septic shock, the elevation of DEB's pulmonary capillary wedge pressure to 16 mm of mercury without a significant increase in cardiac output suggests that an optimal pulmonary capillary wedge pressure has been reached. Therefore, additional fluid therapy to maintain BP may cause pulmonary edema and compromise pulmonary gas exchange. A plot of cardiac output versus pulmonary capillary wedge pressure ventricular function curve would provide a more accurate assessment of the pulmonary capillary wedge pressure at which cardiac output is maximal. Additional fluid boluses at this time should be used only to maintain the current level of intravascular volume status. Let's look at vasopressors and inotropic agents. When fluid therapy fails to maintain a satisfactory MAP despite an elevated cardiac output, the use of a vasopressor should be considered. Maintaining a goal MAP does not correlate with decreased mortality, but it helps sustain myocardial and cerebral perfusion. If it is necessary to increase cardiac output, then inotropic agents should be used. Although the use of inotropic agents is well established, controlled comparative studies have not clearly determined which agent, or combination of agents, is most useful in the management of septic shock. Because differences among the inotropic agents are significant, however, selection of the most appropriate drug should be guided by careful consideration of the patient's hemodynamic status. Next we will look at norepinephrine and dopamine. Norepinephrine is predominantly an alpha-adrenergic agonist and is the recommended first-line vasopressor for sepsis. Norepinephrine has been titrated to 0.3 micrograms per kilogram per minute, but DEB's heart rate will likely limit the utility of further increases in the dose. Dopamine has frequently been another initial pharmacologic agent chosen for the treatment of septic shock. The trial that randomized 1,679 patients with shock to dopamine or norepinephrine for BP support found no significant difference in the primary outcome of 28-day mortality but an increased risk of arrhythmic events with dopamine. A meta-analysis of 6 randomized trials of septic patients found dopamine was associated with an increased risk of death and arrhythmias compared to norepinephrine. Similarly, another meta-analysis that included 6 randomized trials found norepinephrine was associated with a lower in-hospital and 28-day mortality compared to dopamine as well as a lower incidence of arrhythmias. In light of these findings, the Surviving Sepsis campaign relegated dopamine from a first-line to alternative vasopressor. Dopamine is now reserved for patients with absolute or relative bradycardia and a low risk of tachyarrhythmias, which is difficult to predict. Accordingly, dopamine is not an appropriate therapeutic option for DEB. Low-dose dopamine should not be used for renal protective purposes. Despite the improvement in renal blood flow and a possible increase in urine output, dopamine does not decrease the time to recovery of renal function or the need for renal replacement therapy. Next we will look at epinephrine. Epinephrine stimulates alpha, beta-1, and beta-2 adrenergic receptors. Cardiac output is augmented via increased contractility and heart rate, with the contribution of each being highly variable. Blood vessels in the kidney, skin, and mucosa constrict in response to alpha-adrenergic stimulation, whereas vessels in the skeletal muscle vasodilate because of beta-2 effects. A biphasic response in systemic vascular resistance is observed as beta-2 receptors are activated at the lower range and alpha-1 receptors are stimulated at higher infusion rates. The improvement in cardiac output, therefore, may be negated by an increase in afterload at higher dosages. Historically, epinephrine was reserved as a last-line therapy because of the studies that showed harmful splanchnic and renal vasculature effects and elevated lactate levels. Despite these effects, there are no clinical studies showing that epinephrine causes worse outcomes in sepsis. In fact, 2 prospective, double-blind, randomized controlled trials comparing epinephrine and norepinephrine in patients with septic shock found similar mortality rates, time to hemodynamic recovery, and time to vasopressor withdrawal. Both studies showed lower arterial pH values associated with impaired serum lactate clearance in the epinephrine-treated groups. Therefore, lactate clearance would not be recommended to guide resuscitation when utilizing epinephrine. Epinephrine is recommended as adjunctive therapy to norepinephrine to maintain adequate MAP. However, if tachyarrhythmias are limiting the use of norepinephrine, epinephrine is likely to produce similar effects because it also stimulates beta-1 receptors. Consequently, it is not appropriate to substitute epinephrine for norepinephrine at this time for DEB. Next we will look at vasopressin. Catecholamines have been the mainstay of treatment to support BP in septic patients once adequate fluid resuscitation has been achieved. Sepsis, however, can cause a decrease in responsiveness to catecholamines, resulting in refractory hypotension, possibly because of down-regulation of adrenergic receptors or altered receptor-relative binding affinities in hypoxic and acidotic conditions. Vasopressin is an endogenous hormone that has very little effect on BP under normal conditions, but it becomes important in maintaining BP when the baroreceptor reflex is impaired. In contrast to the catecholamines, vasopressin's effects are relatively preserved in hypoxic and acidotic states. Vasopressin's direct vasoconstricting actions are mediated by the vascular V1a receptors coupled to phospholipase C. When these receptors are activated, calcium is released from the sarcoplasmic reticulum in smooth muscle cells, leading to vasoconstriction. Vasopressin levels peak in early septic shock and decrease to low normal levels in most patients within 48 hours. This phenomenon is coined a relative vasopressin deficiency, because higher vasopressin levels would be expected in hypotensive states. The VAST study compared norepinephrine to vasopressin in patients with septic shock, who were unresponsive to fluids and assessed mortality at 28 days. Vasopressin 0.01 to 0.03 units per minute added to norepinephrine was compared to norepinephrine monotherapy. Vasopressin significantly decreased the amount of norepinephrine required. However, there was no difference in mortality between the treatment groups except when the patients were stratified according to severity of sepsis. The patients with less severe septic shock benefited from vasopressin therapy. This study evaluated vasopressin as a catecholamine-sparing drug rather than as rescue therapy for catecholamine-unresponsive shock, which was how it was studied in previous trials. Small studies have shown vasopressin to be as effective as catecholamines in achieving blood pressure control with no difference in mortality, but vasopressin is not recommended as first-line therapy because of a delayed physiologic response. Instead, low-dose vasopressin, up to 0.03 units per minute, is recommended to synergistically achieve the goal MAP with norepinephrine or allow norepinephrine dose reductions. Doses higher than 0.03 to 0.04 units per minute are only recommended as salvage therapy. DEEB has a decreased MAP despite the increased titration of norepinephrine. The optimal time to consider additional or alternative therapies to norepinephrine is unknown. Because patients in septic shock have decreased endogenous levels of vasopressin, it would be reasonable to add vasopressin at 0.03 units per minute to increase the MAP and renal perfusion. Next we will discuss phenylephrine. Phenylephrine is a pure alpha-adrenergic agonist and, thus, increases systolic, diastolic, and mean arterial pressures through vasoconstriction. Reflex bradycardia can occur secondarily because of the absence of beta-adrenergic effects. The increase in afterload, while increasing myocardial oxygenation, correspondingly increases coronary blood flow because of increased perfusion pressure and autoregulation. In patients with myocardial hypoxia, or in those experiencing atrial or ventricular arrhythmias, phenylephrine can be beneficial because it has minimal direct cardiac effects. In situations in which the cardiac output is decreased, phenylephrine can be detrimental. Preload is reduced as plasma fluid is lost owing to increased capillary hydrostatic pressure, forcing water and solutes from the vascular space into the interstitial spaces. This response, in addition to the increased afterload and reflex bradycardia, may significantly impair cardiac output. Therefore, phenylephrine should be reserved for treating septic shock in the following patients. A. Those with arrhythmias on norepinephrine. B. Those with high cardiac output but persistent hypotension, or C. Those who fail to achieve the goal MAP on combination inotropes or vasopressors and low-dose vasopressin. Phenylephrine is a reasonable alternative therapy for DEB if her hypotension and tachycardia persist despite the addition of vasopressin. Next we will discuss dobutamine. Tissue oxygen delivery may be impaired by a suboptimal cardiac output or decreased oxygen carrying capacity. If tissue hypoperfusion persists after optimizing fluid status, achieving the goal MAP, and assuring an adequate hemoglobin concentration, then cardiac output should be assessed. Epinephrine and dopamine are inotropic therapies with vasoconstricting properties, but dobutamine is the recommended first-line inotropic agent in the management of septic shock. Dobutamine produces a greater increase in cardiac output than dopamine, but it also lowers systemic vascular resistance. In contrast to dopamine, dobutamine lowers pulmonary capillary wedge pressure and causes less pulmonary shunting. Because dobutamine can lower ventricular filling pressure, volume status must be monitored closely to avoid the development of hypotension and reduced MAP. Fluids should be administered as needed to maintain the pulmonary capillary wedge pressure at optimal and tolerated levels of 15 to 18 mm of mercury. With the administration of greater amounts of fluid, cardiac output, oxygen delivery, and systemic O2 are significantly increased. Dobutamine increases oxygen delivery and cardiac index when given concurrently with or after volume resuscitation, and it may independently increase capillary perfusion regardless of systemic effects. Decreases in PaO2 and increases in venous PO2, as well as adverse effects on myocardium, may be evident at higher dosages, above 6 micrograms per kilogram per minute. Combinations of vasopressors and inotropic agents can also be used to achieve desired hemodynamic parameters. GI perfusion can be compromised owing to the vasoconstricting effects of catecholamines and may play a role in the pathogenesis of multiple organ dysfunction. Currently, it is unknown whether a specific catecholamine regimen provides a significant benefit over others. There are conflicting data about which vasopressor can increase gastric perfusion and whether this increase can alter progression to organ dysfunction. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 322.